Good afternoon and welcome to the Becker's ASC virtual event. We're so excited for you to join us for today's panel, The Next 5 Years for ASCs. I'm Alan Condon with Becker's Healthcare and I'll be your moderator for today's panel. This session is being recorded and will be available on demand following today's event. We'll send you instructions on how to access the recordings once today's event concludes. At this time, it is now my pleasure to kick off today's panel by introducing our presenters. Speaking today are Matthew Ewasko, Administrator at Physicians Alliance Surgery Center, Jason Strauss, Chief Operating Officer at Surgical Care Affiliates, Dr. Bill Berryhill, Managing Partner of Hybrid Cath Lab and Surgery Center, and Dr. Paul MacKoul, Co-Founder of the Center for Innovative GYN Care. Let me first say it's a real pleasure for you all to join us for today's discussion, so thank you so much for making the time to be here.
Thanks.
All right, and without further ado, to kick things off, we're going to go to you, Dr. Berryhill, to kick us off for this discussion today. Obviously, this year has seen significant investment in telemedicine, remote patient monitoring systems, and contactless payment systems. Well, what do you see as the next big technology investments for ASCs?
I think it's going to be in the field of communication with our patients. Over the last several months, we found out that almost on a weekly basis, what we have to do in the preoperative stages has changed. And also, as different procedures are being performed, in our case, addition of cardiology patients, if they become ill or have a problem, or even in today, if somebody has a fever, you have to change your schedule around on that day and communicate with your patients very quickly.
Okay, fantastic. So we got communication and scheduling there, and let's go to Matthew. How about you? What do you think? What do you see coming down the pipeline in terms of the next big technology investments for ASCs?
Yeah, I think I'll agree with what Dr. Berryhill just mentioned. The communication. We recently implemented an app that our surgeons can have on their phone or their iPad that gives them real-time view into the patient scheduling. So if there's any kind of updates, they can see that, as well as their office, which will really speed up and help with any changes for block schedules or anything like that. But we're also looking at really making our patient check-in process and overall experience more remote, and to give not only the patients but their family members visibility into what's going on, since in the time that we're in now, the patient waiting areas are really not being used. So we have patients waiting off-site in their vehicles and whatnot.
Okay, fantastic. So patient scheduling or switching your process to a more remote system. Are you seeing the same things at your practice, Jason?
Yeah, so I would just kind of bucket into three ways that I see technology over the next 5 years. First, would echo what Bill and Matthew said, is how we better communicate with our patients. We had to do so through telemedicine over the course of COVID, and would expect to see that over the course of the next 5 years. The second thing I would say is, as more and more technology enables procedures to shift to the outpatient surgery center, surgical hospital, or hybrid environment, we will inevitably invest in additional technology to enable procedures to be done. And then last, I think, is how do we get paid? And so how do we invest in technology that enables payment, whether that's directly from health plans out there or through large employers, and ensure that we're able to communicate to those patients, capture them at the surgery center, and then ultimately that we're able to get paid by whoever the payer is. And that's where I see we'll invest as an enterprise over the next 5 years.
Awesome. Thank you, Jason. And Dr. MacKoul, I'd love to get your insights here on this one as well.
Yeah, taking off that, it really comes down to payer contracting. If you can get payer contracting where you need it to be, you can run a very successful ASC. We've done that to the point where we can sort of move into something very expensive, the technology being workable in a surgery center, which is robotics. Why robotics? Because GYNs use robots. There's a lot of different reasons for that. We particularly don't use a robot on a day-to-day basis, but bringing a robot in increases access and exposure, increases volume. With the appropriate contracts, you really got a win-win situation for the patient and the physician, and of course the ASC.
Fantastic. Yeah, I love the addition of the robotic system to your practice there. It's certainly an interesting one. And Dr. MacKoul, we're going to stick with you for this next question as well. A bit of an interesting one. I'd love to get your insights on what specialties are still profitable in ASCs today, and do you see remaining so within the next 5 years?
If you think about orthopedics 15, 20 years ago, that was it. What did they do? They brought in new procedural technology. They used technology to pull patients from the hospital right into the ASC. GYN is more difficult. OBs are typically OB-centric, right? They're not doing a lot of surgery. So CIGC developed technology to actually do that for GYN cases. It's a high volume specialty. It's low impact as far as implants and cost, but you can certainly bring those patients into an ASC. And interestingly, CMS actually increased reimbursement on GYN cases 25% about 2 years ago. It's actually second only to ortho on in-network payments. So you're looking at really the new frontier for ASCs. If we can bring high volume GYN surgeons into surgery centers, we're going to see some good volume and some very good payments.
It's certainly an interesting point there. And Dr. Berryhill, I'd love to get your thoughts on this, coming from, of course, as an orthopedic surgeon. Have you anything to add here?
Well, I think in orthopedics, the thing that is the big movement is moving towards total joints. That's going to take some time for people to get ready for it from just the standard ASC, because you're going to have 23-hour observations, and you're also going to look at getting agreements and contracts, which once again is the most important part of this. Can you get the contract that will pay you to perform that procedure? Currently, that's not open to most contracts under commercial payers. Of course, if this moves in Medicare and Medicare approves it, then eventually the commercial payers will follow. But the things that we see that are payable and areas that are profitable are both orthopedics and cardiology, and which is moving more to the outpatient setting. Also ENT, and then the other things that we see that are profitable, but we don't do in our center because we need the high volume, like in the gen, is ophthalmology and GI.
And Jason, I'd love to go to you on this one. There's certainly a ton of specialties there making waves. Where would you be investing the majority of your time and resources in the next few years in terms of expansion and into new specialties?
Yeah, it's a great question, and I think, like Paul and Bill said already, how do we focus on improving our efficiency, and then additionally working with the various health plans that are not Medicare to find the right payment constructs. Surgery centers have gotten their history around being able to be profitable at getting paid 50% of what hospital outpatient departments are paid by Medicare. So how do we work with health plans to continue to create structures that enable procedures to transition from the hospital outpatient department to the surgery center? And I could envision that some subspecialties will transition into the office to create space for the higher acuity cases that we'll be able to continue to see and expand as technology improves and payment constructs improve as well.
And then Matthew, you agree with our panelists here. Is there anything we're missing out on in terms of, what may be a particularly profitable specialty in the ASC market in the future?
No, I mean, I think it's been kind of a common theme amongst all of us so far, but for us, our focus now is on our orthopedic service line. We do have the ophthalmic and the ENT, which are great for us from a volume standpoint. But our orthopedics is where we can really start to focus in on and continue to see the profit margin, especially if we're going to continue with total joints moving away from the inpatient hospital only and moving towards the ASC arena. That's something that is going to definitely require our focus and attention over the next year and going forward.
Yeah, absolutely. And I'll just stick with you for this one, Matt. Obviously, you touched on it a little bit there. Before the pandemic, we've seen the migration of total hip and knee replacements to the outpatient setting, which is only seems to be amplified by the pandemic. how can ASCs best position themselves to capitalize on the migration of these procedures to the outpatient setting?
Yeah, I think the most important thing, and something that we've started already for our ASC, is reviewing all your payer contracts, and then start working with your reps for each payer. Talk to them, let them know that, hey, we're looking to go into this this venture, and start working on renegotiating those contracts to make sure that your reimbursement is there. At the same time, you need to really start working with your vendor reps, finding out what your true supply costs are going to be, and go from there. And really just making sure you have all the groundwork and all the legwork done prior to getting those surgeries started.
Fantastic. And any tips at all in terms of renegotiating these contracts with payers? Is there any kind of keys or lessons learned from prior negotiations? Jason, I'd love to get your insights on this one.
Yeah, so as far as working with the health plans, I mean, often the feedback that we've gotten from the various health plans across the country is typically people come with a handout versus here's how we're going to ultimately create programs to save the health plan, the insurance, self-insured employer and or the patient money, and by doing so land at the right spot where it's a favorable contract for the surgery center. So it's really trying to put yourself in the health plan's shoes to understand what's current market rate today and how can you create a value to the health plan while also creating value to the surgery center. And to build on what Matthew said with respect to positioning ASCs, I mean, the first and foremost is starting with the clinical protocol. So how do we get the right patients into the surgery center and the right pain management protocols and the right rapid discharge? That's where our focus has been as a company, is to stand up a team that does nothing but focus on total joints, spine, cardiovascular procedures, so that we're ensuring that as we're transitioning the patients, we've got the right patient criteria with our local physician partners to ensure that we're starting off in a good spot, and that we're ultimately picking the right patients to begin with as a individual surgery center, bringing the right protocols and ultimately doing so with the pain management in our mind, as well as each individual state has various discharge protocols, and we got to ensure that we're getting the patients discharged appropriately depending on each state's regulations. So that's kind of where we're investing a lot of our time thinking through, is the clinical aspect of ensuring the right patient and the right locations at the right time.
Fantastic. So what I'm hearing is focusing on the clinical protocols, obviously working with your vendors and focusing on those payer contracts. Dr. Berryhill, I'd love to go to you and get your insight. How are you shifting your orthopedic practice at this moment to take advantage of this this outpatient migration?
Well, first thing is you have to get the orthopedist to buy into it. I mean, you have to remember that there's a lot of physicians who are so accustomed to doing this in the hospital that the idea of doing it as an outpatient, I mean, they won't even listen. So first of all, you have to get them to buy into it, and then you have to get them to be a part of the program. They have to get them to help set it up, and you have to bring in all the different things that are involved with it, because it's both preoperative teaching to the patient, and then it's the operative care. And as Jason said, pain management is a extremely important part of this, and you got to have your anesthesiologist and your pain management on board, and you have to have an education and a program. And as I said, everyone has to buy into it. And then just simple things like vendors. You would like all your orthopedists to be buying or getting the same total joint, using the same vendor, so that you can increase your numbers and help with your contracts and your costs and everything involved.
Absolutely. And Dr. MacKoul, anything you'd like to add here, even give from the OBGYN aspect, anything like any final thoughts from you here?
Well, I'll tell you, I would love to bring orthopedics into my ASCs, but there's not a lot of orthopedics around that can go into these ASCs because they're already in an ASC. So looking at it from the other standpoint, how do you get a payer, first of all, to increase reimbursement? What we do is publish. So we're providing something to the payer to latch onto. Those publications are about major GYN case outcomes in ASCs and hospitals, and they're also comparing those major GYN outcomes like hysterectomies and myomectomies in the ASC setting to the hospital setting with a cost frame on there. So when they look at that, they go, wow, you're really doing some interesting work. You have successful outcomes of these high volume procedures in your surgery centers. We're going to increase the payments on your contract. So I love ortho. Ortho's done a lot for ASCs, but we just don't have a lot of orthos that are free to do ASC work because they're already tied up in those ASCs. So GYN offers a sort of a different alternative and a high volume one. You just got to get the right doctors in. It may not be for most OBs to come into a surgery center, but it certainly would be for GYN oncs and for high volume specialists. And that's really where volume and the payout can be quite good.
Absolutely. And Dr. MacKoul, I'm actually going to stick with you for this last question as well. You had an interesting point there, obviously, with the robotic investment that you mentioned earlier in this conversation. I'd just love to get your insights on it. It's always an interesting one for obviously see what else is going on in other specialties. What are the key areas that you aim to expand at your organization in the next 5 years, and why?
It's actually going to be a flex of both robotic and non-robotic. Obviously, you can do better financially with non-robotic cases. You can get them done faster, more efficiently with the right technique. But again, a flex situation is how can I increase volume in that ASC? If your contracts are good, and again, you got to beat the data over the head with the contractors. Here it is, and you'd have to develop and schedule meetings with medical directors and coders and everybody so that they understand what you're doing. If you get there and you get the contracts where you want them, then you have that flexibility to pull a robot in. It would be for hysterectomies, myomectomies, urogynecology, a huge issue. And believe me, a lot of general surgery and urologists want robots as well. So now you're pulling patients from the hospital setting into a very exclusive ASC with a robot in place. You can lease robots, you can rent robots. You'd be amazed the interest in that. A lot of people want to come in, they don't want to have to deal with booking problems at the hospital. They want to come in and use one room, some even bounce to a second robotic room. It might be where ASCs are going as long as it's financially doable.
Robotics obviously such a huge trend in the field at the moment, especially in orthopedics. So Matthew, I'm going to go for you. How are you looking at expansion and growth at your organization over the next 5 years?
I think I'll piggyback on what Dr. MacKoul just mentioned, the use of robotics. The key thing for us is making sure that it's financially feasible. There's, like you said, obviously there's lease options, there's rent options, there's always the purchase option. A couple years ago, we invested in some technology for our ENT service line for them to provide image-guided procedures, which has enabled them to bring additional procedures to our ASC that they couldn't do elsewhere. We are looking at that option for our orthopedic and possibly use for our general or OBs that do use our facility. So it is something that is definitely on our roadmap, and our number one question is this improve our patient outcomes? Is this something that gives us more overall efficiency? And is this something that is going to be utilized and then worth the investment?
Okay, absolutely. So we've got, looks like robotics seem to be the trend of expansion for the next few years. Jason, how about you? What does expansion look like for your facility over in the near future?
I'll take it a little bit of a different direction. So as a company, Surgical Care Affiliates has historically been surgery center investors and managers, surgical hospitals. And then 2 years ago, we started to evolve to be a specialist alignment company. So started investing in physician practices through MSOs, so we can help practices continue to grow and have opportunities for physicians to join practices out of residency and fellowship or come out of health system employment. And so I see our growth, in addition to what Paul and Matthew have outlined, is expanding through robotics and other different procedures, is investing in other ancillaries to wrap around the surgery center and surgical hospital through specialist alignment company. And that can be through businesses that help educate patients and get them to practices that are going to lower cost surgery centers, or it could be through expansion into growing practices in a given geography where we're already today. So that's how I see us growing over the next 5 years, which is expanding outside of the four walls of the ASC hospital hybrid into working with physician partners in a deeper way than historically SCA has.
Okay, fantastic. Thank you so much, Jason. And of course, Dr. Berryhill, how is growth at your center looking in the next 5 years?
Well, I think I have to agree with Jason that the biggest thing is the growth of the physicians who use your center. If they have a practice and they're adding physicians to that practice, then your center is growing. So in our community, there's two large hospital groups, and then there's a group of independent physicians, but that group is relatively small, and so you're limited. But our areas of growth are most likely going to be primarily in the field of cardiology. And over the next 5 years, with the changes that are going to occur, I think, in ASCs, then we're looking at moving into even the electrophysiology field of cardiology, in which we'll be doing heart ablations and other procedures that are at this time only done in the hospital.
Okay, fantastic. It was certainly really interesting to get all your insights there, especially on expansions and where you're focusing over the next few years. That's all we have time for today, but I'd like to thank each and every one of you, all our presenters, for your time, thoughtfulness, and insights today. Before we close out, I'd like to give each and every one of you one last opportunity to share any final thoughts. So Dr. Berryhill, we'll stick with you. I'd love to get your 30-second takeaway from today's panel that you'd like to share with our audience.
Well, I have to agree with all the panelists who spoke. We talked about picking the right physicians, where you can have an ASC that it can be limited to gynecology, it can be limited to ophthalmology, it can be limited to a special entity as long as you get a high volume. And then I think the other thing is that in orthopedics and in cardiology, we're looking at higher paying entities, which the volume doesn't have to be as great. And then with Jason's statement about making sure you bring in the right physicians, what an important aspect that is. But I think that goes across everyone who's spoken. Matthew also is, if you have the right group of physicians, you're going to end up with a successful center.
Absolutely. And Jason, let's move on to you. Your 30-second takeaway that you'd like to leave our audience members with.
Sure. I think it's if anything, COVID has displayed how relationships are really important, and they've been important historically, and they're going to be important going forward. And so how do we open our minds to new partnerships, new relationships with medical groups, hospitals, doctors, health plans across the country that ultimately do what we need to do, which is take care of each patient that comes into our ASCs on a daily basis and try to reduce the cost of the healthcare in our country. And so just please be open-minded to the relationships that you have in your given geography and your given market that will allow us to come up with new solutions and new innovations that we probably can't imagine today.
All right, thank you. And then Matthew, let's move on to you. Your 30-second takeaway.
Yeah, I think Dr. Berryhill mentioned this earlier when we were talking about the total joint migration, but I think in anything that we do, we need to make sure that we have the buy-in of our physicians and our surgeons. Without their buy-in and support, you're not going to make any headway on it. I think the same goes for the staff members, not only the clinical staff members, but the clerical ones. Communication with everyone is going to be key, and making sure that everyone is on the same page and that we are all moving towards the same goal. Keeping everyone updated, especially what we've been doing through this COVID time, has been great for our facility, and everyone's on the same page, and we're all working towards the same goal and moving in the right direction.
Absolutely. And last but not least, of course, Dr. MacKoul, I'd love to get your 30-second takeaway from today's panel as well.
Yeah, we're very interested in stability. The concept of bringing in a practice and even buying the practice into the ASC limits the number of doctors in the ASC. I think having 50, 75 doctors is always going to be a problem, but having 10 or 15 high volume committed surgeons to that ASC, affiliated or owned by it or with it, all right, structure, it gives you such a peace of mind. People work together better, volume increases, you develop a family unit. That family unit really is so valuable to us. I think that's what makes ASCs grow and expand. So that's what we're really looking for.
Absolutely, fantastic. There's some great insights from each and all of you there, and I want to thank you one last time. I really appreciate your time today. And to all of our attendees who joined us, thank you so much for taking the time to be part of our Becker's ASC virtual event. We look forward to seeing you at future Becker's events. Thank you.
Thanks much.
Thank you.